This is an age of disruption, of profound revolutionary change.
What we're really asking ministers is to empower the ambassadors.
The only thing that you really push forth is the truth.
You don't see many women represented when it comes to the decisions as to how to handle the pandemic.
Good afternoon, everyone. Thank you all for coming back. My name is Sarah Taysir Ben-Sharif. You can call me ST for short, and I'm a health reporter at Politico. I'm really looking forward to the exciting conversation we have ahead of us today and with our esteemed panelists. But before I introduce them, I just want to tell you why we're talking about non-communicable diseases. With much of the attention of the last 2 years focused on the ever highly transmissible coronavirus, we're shifting our attention to something that is inherently non-transmissible and perhaps a little bit less sexy, the NCDs. But really, they are the silent killers. And we're doing so with good reason. It's hard to overstate the burden that NCDs have on the world. According to the World Health Organization, they kill 41 million people per year, and they account for 3 out of 4 deaths. Cardiovascular diseases make up most of the NCDs. And you know, not to get a little too dark too early, but it's in all of our interests to talk about this problem and talk about the solution, because to be frank, if we look around you, most of us will die of an NCD. Sorry to break it to you. Starting on the little bit of doom and gloom, but in fact, it's not all doom and gloom. So I hope that today we'll be able to look at the issue from many angles. We'll talk about what the pandemic revealed about NCDs. We'll talk about how to reduce the backlogs in care and in screening. And we'll take a critical look at the attention that prevention does, or perhaps doesn't, receive. But first, I'd like to introduce our panelists. First, we have Franz Weidinger, President of the European Society of Cardiology. Joining us remotely is Marianne Taki, Team Leader on Disease Prevention and Health Promotion at DG Santé in the European Commission. And last, but certainly not least, we are joined by Tomislav Sokol, Croatian member of the European Parliament with the European People's Party Group and a member of the ENVI Committee. And of course, there is each of you in the audience in person and joining us remotely. So I look forward to your great questions. Please submit them via the swap card platform. The instructions to do so are, if you're in person, on the little leaflet on your chair. And if you're on a desktop, you'll see it at the top right of your screen. And if you're fancy and you've got a little mobile device following at home or something, it's just below the live stream. So without further ado, I'd really like to get started by setting the scene first, painting an idea of the scope of the problem of NCDs. It's becoming increasingly clear that the coronavirus pandemic really changed the landscape when it comes to NCDs. And so, Franz, I'd like to start with you. You know, you wake up in the morning, you put on your white coat, you don your stethoscope, you get to the clinic. What are you seeing at the bedside? What are patients telling you when it comes to their lived experience of NCDs? And how has that changed in the last couple of years? Walk us through that.
Well, first of all, thank you for the invitation to this conversation. It's a good point that you make. I think the pandemic really showed us that we feared that patients wouldn't seek medical care timely enough, because we know that heart disease may be something that really requires rapid action when it comes to myocardial infarction mostly. So during the first phase of the pandemic, when there was a complete lockdown, we did see very alarming reports all over the world that patients came late, and there were longer delays until reopening of the artery in the case of myocardial infarction, which may cause death or, you know, a more severe course of the disease. So we did see patients with in worse conditions with myocardial infarction than we were used to. So this is the situation now after the pandemic fades away, let's say. We have this backlog of treatment. We see more complex patients, because even now, when patients come for planned procedures, we do see more severe, more complex disease, which raises the concern that also these patients who are not acute, they may have sought medical care later than they used to do.
Thank you for bringing us into your clinic and to the bedside with your patients. And I'm glad you mentioned backlogs, and we'll touch on those in a minute. But Tomislav, I want to go to you. You know, perhaps one of the added stressors that we're seeing from NCDs is A, they were already a big problem, but B, they're growing. So we're seeing a surge in mental health cases. We're even dealing with a new entity altogether, long COVID. And I'm keen to hear, you know, where do NCDs fit in the list of concerns that your citizens share with you? And what are you hearing on the ground?
Yes, definitely NCDs are one of the major problems. People, in many cases, people are generally reluctant to talk about healthcare issues. So it's not something that you talk in bars or when you go to a restaurant or something. But definitely that has come to be proved as a big problem. For instance, I'm glad that you mentioned mental health because we already have some data. The lack of data still is the problem, and this data is very dispersed and from different member states. There are different situations, but definitely mental health caused by all of the shocks which COVID produced is definitely proving to be a major issue. I would like to mention, for instance, children, people and young people who were not able to attend their schools or universities, or there are people who spend half of their studies in the universities completely online, and this is something that definitely has big consequences. We still don't know the real amount and the real effects of this. We will know this in the years to come, but this is something which is definitely a major issue, and now it is the time, really, after. Of course, COVID is still not over, but now we are in a situation that we can really focus much more of our efforts of the capacity of healthcare system on actually tackle all of these problems. So the backlogs, the old issues, but these new issues that you mentioned, which also arise because of COVID.
Absolutely, yeah. That brings me to my next question for you, Marianne. So from a public health perspective, how can health systems be designed so that they're resilient enough to be able to quickly absorb the new weight of an emerging condition like the coronavirus pandemic or long COVID, or when it's more specifically things like long COVID and mental health? How can health systems better address the surge in NCDs? And how can they do so in the face of a growing concern with the very mental health and burnout among healthcare workers?
Thank you. That's a very complex issue you raised. First of all, I want to say that health systems, of course, and health services are the responsibility of the member states. So what the Commission is doing in this area on NCDs, and especially after the pandemic and the backlogs and everything that the colleagues in the panel mentioned, we try to support the member states in achieving the Sustainable Development Goals and in addressing the needs of the population through EU funding, for example. We have a big new program, EU for Health program, which provides actions that can be used for this kind of purposes. Now, it's up to the member states to decide what kind of actions they want, but we try to help them to prioritize and come together during the spring when we organized so-called Healthier Together EU NCDs initiative. And during that time, we wanted to find out from the member states where are they now with the internationally agreed targets, the SDGs, but also with the WHO's NCD targets and the consequences of the pandemic. And as a result, we are now going to fund, and big projects are going to be launched early next year. We will have joint actions on cardiovascular diseases and diabetes, but also on health determinants, which cover many areas as a whole. Now, mental health was also mentioned, and there we already have quite many projects because mental health issues were a concern at the EU level already before the pandemic, but of course the pandemic made them more difficult, like the Honourable MEP just mentioned.
I'm glad you mentioned the efforts of the European Commission to tackle it. The Healthier Together initiative is $156 million. There's a growing amount of attention that's given to NCDs, but I'd like to kind of challenge a little bit and say, you know, you did say that health is a national domestic competence, and I just want to know, if you had to give me the elevator pitch, what's the real added value of an EU-wide initiative like this one?
Well, I think EU added value is when we can share best practices, we can share knowledge and experiences between countries. You can take one small region in Finland, for example, the country I know best, in Lapland, and sometimes in small regions you can create innovative approaches, best practices that in fact can be useful elsewhere. So this sharing of best practices, sharing of knowledge, this is where the EU added value comes horizontally on health problems into the picture.
Okay. I want to ask you, yeah, go ahead.
I want to comment on that. Now, Healthy Together initiative is a good thing, but I think we have to do more. And I think a good example of what we can do and that we can be much more ambitious is the Europe's Beating Cancer Plan. Because Healthy Together initiative provides, yes, exchange of best practices, supporting the member states, also certain actions to be made. But what we need is, what we have in Europe's Beating Cancer Plan is we have concrete targets, we have concrete benchmarks, we have concrete timeline, and we have concrete funding. And I think this is what we did. For instance, for Europe's Beating Cancer Plan, it is allocated for its implementation around 4 billion euros. So this shows you these relationships. So I think especially for the most important, let's say, or the most dangerous non-communicable diseases, like, for instance, cardiovascular diseases or mental health diseases, I think we need something similar. So there is a possibility. Of course, member states are responsible for financing and organizing and managing their healthcare systems, but with common European policy, we can do much more. So provide funding, exchange data, provide standards on cross-border care, because a lot of things that we do on European level for cross-border situations where you have competence to act, then spill overs also to the national healthcare systems afterwards. So I think this is a good start what the Commission is doing, but I think we have to be much more ambitious with much clearer objectives, more ambitious objectives, and much stronger funding and more concrete timeline than we have now.
Okay. Friends, I want to know, does the Commission's initiative align with what you feel are the priorities at the bedside when it comes to tackling NCDs? One of the comments I've read and heard in speaking to people about it is that it's a great initial initiative, but it's a bit general, and like you mentioned, it may be lacking in specificity of targets. I'm wondering, how does it align with what you're seeing at the bedside?
Well, I think it's a great opportunity to first of all, to look at harmonization of data. This is one part of the initiative. I think this is very important because also the European Society of Cardiology has several projects and initiatives to collect data. And I think this is a field of opportunity for collaboration among EU member states, but also ESC member states, which is even a broader community. So the ESC does a lot to collect data in order to improve the quality of care. So I think the pandemic has sparked interest in harmonization of data and also, hopefully, in increasing activities in terms of registries. So we have 3 pillars of data collection. 140,000 patients already recruited in registries, and another initiative called EuroHeart, which aims at really a broader, long-term, continuous quality improvement, quality of care a program that also enables to recruit patients in studies. That's, I think, important for the future to perform registry-based randomized controlled trials. So this is one aim, and the model, of course, is Sweden and more recently the UK that have achieved to do registries of that scale. And the ESC wants to embark in this, and really, I think for this, it needs a broad collaboration among European member states and the whole community. So there's a big hope in this EHDS that has been launched this year. Hopefully this will be true in the next decade. So this, I think, even though health policy is set at the national level, I think it's an important stimulus if the EU puts forth something like EHDS. Absolutely.
Thank you. I just want to remind the audience, feel free to put in your questions through the app. You've both mentioned the importance of health data, and that seems to be a recurring theme. And when we talk about health policy, we can't know what we're dealing with unless we have data to back us up. One of the pieces of data that's emerged over the course of the pandemic is the care and treatment backlog for NCDs. In some instances, I feel like we have a decent picture of what the backlog looks like, and in others, I don't feel that we do. It's a bit of an ambitious question, but I just want to know, like, how do we dig ourselves out of that backlog? Maybe we'll start with you, Franz.
Could you repeat that?
How do we dig ourselves out of the care backlog when it comes to NCDs? Like, what's worked? What have we tried? What's failed and flopped?
I think, most healthcare systems have struggled with, bed capacities, hospitals. So with all the healthcare systems really focusing on in-hospital care, I think this is the chance maybe to envisage health systems that are, more transversal, more integrative. So to really look at the future that includes, primary care settings, in-hospital and acute care setting, to really broaden the scope of health promotion and disease prevention. So I think the best preparation for the next pandemic or next emergency situation like this is to enforce prevention, primary prevention and secondary prevention, because this is the only way to really reduce the burden of disease. And as you already said, cardiovascular disease is still the #1 cause of death worldwide, and it's increasing in low and middle income countries. So this is alarming. And it's not only related and associated with the aging population, it's also 38% of premature deaths, defined as below 65 years of age, are due to cardiovascular disease. So I think there's a lot of reasons to enforce a broader aspect of health promotion and disease prevention in the cardiovascular domain, but also, of course, in the NCD domain in general.
I think one thing that the pandemic has shown us, that we really neglected primary care in general. It's not sexy. So when you think of healthcare, new technologies, we always focus on secondary, tertiary care, big investments, big new equipment, things like that, new expensive medicines, etc. But primary care is the key. For instance, if doctors from primary care just send automatically everybody to get diagnostics on the secondary level, then we have long waiting lists, then we have queues, then we have bottlenecks, etc. So, and because we test people who maybe do not need to be tested, because part of the diagnostics could have been done on the primary level. So we have to invest much more into primary care, into education of primary care providers, into their legal protection, because in many cases they are afraid to do part of diagnostic by themselves because of liability. So we also have to think of that. So I think that's one of the things which all more or less member states have in common. When I speak of the secondary and tertiary care, I think there are really different situations in different healthcare systems. For instance, in short term, yes, better organization, better management of waiting lists, transferring of certain personnel to some other areas of diagnostics and treatment when they are more needed. But also, if we think of long term, some member states have structural problems that need to be resolved. For instance, especially countries in the eastern part of Europe have big problem of lack of healthcare personnel, not just doctors but also nurses, because a lot of those people just went to Germany, France, Sweden, and all these richer member states which can offer better working conditions. So definitely we have to invest more into workforce in those member states, but also in many member states also in basic equipment, because the level of healthcare equipment, you can imagine, is not the same in Bulgaria, Austria, Belgium, and the Netherlands, for instance. And of course, if we have first and second class citizens, then we have such big differences in standards of healthcare provision, we cannot speak about European Health Union or about European citizenship in general.
Yeah, thank you for that answer. You all mentioned the importance of prevention and the need to to focus on prevention. So I did a bit of digging, and I found this Eurostat stat from 2019 that showed that in EU countries, spending on preventive care in general, not just for NCDs, but in general preventive care, ranged between 0.8% and 4.7% of healthcare expenditure. I don't think it takes a math degree to say that that's not a lot. So I'm throwing this to all three of you. What does it take to boost that? I mean, one would say that calamities propel change, and we are in a pandemic. Is there a political appetite to change it given the current situation we're facing?
Yeah, I mean, if I may,
Please, yeah.
I think the crucial thing is to have political will. But you know what the problem with politicians is if I can speak in those terms, is that they always think in 4 or 5 years terms. So they look at only at the next elections. And if you invest into prevention, the effects will be visible in maybe 6 or 7, 8 or 10 years. And that's the problem with politicians when they make decisions. On the other hand, what is great about prevention is that it's very cost effective. So for the least amount of money you invest, you get much bigger return. Because instead of having to pay for all that expensive equipment, which is used to treat people who are already sick, and then the costs are much bigger, and the final results are much worse. So I think changing this narrative and thinking of not just prevention, but special prevention, but healthcare in general, not as a cost, but as an investment into better workforce, healthier people who can contribute more to society is very important. But the crucial thing is to get this through not just European policymakers. I think we have a lot of discussions here and a lot of understanding of this, but to those who make most important decisions, and this is, as was said before, politicians on the level of the member states. And to provide real incentives for them actually to invest more into prevention, and also to provide additional funding from EU budget itself. So we have EU for Health, which is 12 times bigger than the previous health program, but it should be even bigger. We asked for 9.3 billion. The council decreased it to 5.3, which is good but not enough. We have cohesion policy, which was the main source of funding of investing into healthcare from EU budget in the previous budgetary period. Around 25 billion euros were invested into less developed regions for healthcare. And of course, we have recovery and resilience facility, where one of the main priorities is to build resilience of healthcare systems. And what is required from member states to spend that money is they have to actually conduct reforms of their healthcare systems. But then it is important that the European Union actually controls how they are spending the money and whether they are really performing these reforms, or they are just spending the money to cover budgetary deficit or something. Yeah.
Okay. We have a small technical difficulty. Marianne Taki is no longer mic'd in for remotely, so we'll keep you posted when she's back. But Franz, I want to hear from you. I mean, I feel like you do very cool, fancy cardiology things. People come in with chest pain, they've got tiny blocked arteries in their heart, and you do wizardry essentially to unblock these arteries and give them their life back. You're doing the most intense version of. You're seeing the most intense version of the consequence of NCDs not being perhaps addressed early on. What do you want to tell politicians about the importance of prevention?
You're absolutely right, stating that I think 2.8% of health expenditures in Europe is spent on prevention, and cardiovascular disease costs much more, of course, once it's there. So it needs a long-term vision, as you said, and politicians usually think more short-term, let's say, and this is common criticism. So we do need a long-term, broader vision to face the future, because this is one of the biggest, strongest frontiers of cardiovascular medicine, prevention. But having said that, we need research and innovation, of course, because we have to continue to treat cardiovascular disease once it's there at the highest level, and we want to ensure that all citizens in Europe have access to, the best quality of care, the highest level of care that's possible. And so this depends, of course, on national healthcare systems, how much every citizen, no matter of which income he or she has, and which education, and this broader social determinant of disease is there. Everybody should have access to the highest quality of care. So this has also to be ensured by EU health policy, but also national health policies. So I think to assure adequate cardiovascular care for the future and also for future pandemics, we have to think both about prevention, which starts very early in life. We have to address childhood and adolescent obesity and diabetes. So we really need collaboration with other NCD specialists. I think a collaboration needs to be enforced between stakeholders, but also disciplines, to really make the maximum of already existing high technology therapies. And but I really want to come back to research and development. I think we as cardiologists have difficulty in understanding this disparity between the cardiovascular disease being the number one cause of death on the one hand, but very low, comparatively low research funding. And if you look at other statistics, I think only 4% of new drugs that have come out recently are cardiovascular, and the rest is in other fields of NCDs. So I think there's a lot of room for improvement from our standpoint, but I think it does make sense if you look at epidemiology and, despite the advances made in the last 60 years, more than 50% decline in mortality from cardiovascular diseases, it still remains number one. So we have to do more, and we have to think, I think, more long-term and maybe redesign healthcare systems altogether. And this really needs collaboration among European nations, but also, many stakeholders and private-public partnerships, and all of this that helps to reshape healthcare systems.
Okay. Marianne, I just want to hear from you. You mentioned that one of the added values of the Commission is that it can facilitate the sharing of best practices. I'm wondering if you can give us a couple of best practices when it comes to preventive care. Any models that you know of that do it particularly well and that have demonstrated success in reducing the final outcomes, which are the prevalence and then the mortality from non-communicable diseases?
Yes, thank you. So for a couple of years now, we have, together with the member states, started to work on some specific interventions. There's, for example, a few years ago, member states wanted to start transferring a Young 50 best practice, which is about cardiovascular screening of risk factors. In fact, it was developed in I think it was in Lisbon, and it's been now implemented across Europe. Of course, it's very difficult to see about the prevalence and long-term indicators to be looked at in such projects, but together with the OECD, we're trying to gather data, because if we do take this kind of large-scale multi-country best practice transfers, it's very important that we have the evidence that they actually work and they do more good than some other interventions would do. Another good example, I think, would be a new best practice that was submitted to our best practice portal. We have a system where we assess proposals for best practices. It's about screening hypercholesterolemia, which is a genetic disorder in many countries. And again, there, if this kind of best practice would be implemented and transferred across Europe, I think not only would it have a potential benefit, but of course, again, when we talk about screening or large-scale population-level programs, this is where the member states have to tell what they want and what they need. And together with them, we have tried to, under the Healthier Together, really discuss the priority areas. But I agree with the other speakers that, of course, it's not like a Europe-speaking cancer plan. It's not with the specific targets, specific indicators and monitoring and with a huge amount of money. But at the same time, it is first time that we have created such a framework on the main killers in Europe and on health determinants. And I have to say that on prevention, of course, the information is very important, the data, and on NCDs, I don't think the data is at the level of many other, like in health systems, the data is much better. We know about the number of hospital beds per country, but in diabetes area, for example, we don't have that kind of data. And therefore, we are also trying to kick off a feasibility study of looking at what kind of indicators and data we can create, for example, starting with diabetes and cardiovascular diseases. So in prevention, there's still a lot to do at all levels, but also at the ground level, it's important that in healthcare systems, it starts from a very young age, like Professor Weidinger said. It has to be about health promotion, disease prevention, and across all policies. It's only limited what we can do in health systems. It has to be about urban policies, mobility policies. It has to be in education, culture, physical activity, etc. So I think we need to see it also holistically. It's not only about health, it's about many other policies. And health in all policies really is an approach we need to somehow make a bit more concrete and as an instrument also in this area.
Thank you. One of the things that I've been thinking about in the last couple of years is, even though so much attention has been on a communicable disease, the coronavirus, in a bit of a roundabout way, we've also heard about the intersection between communicable diseases and non-communicable diseases. We've seen how patients with NCDs like diabetes, heart disease, kidney disease, they had a higher morbidity and mortality from the coronavirus. And so I feel like it drew a little bit of attention in a bit of a roundabout way to the impact of NCDs. Knowing all of this and seeing all the money that's being invested to better prepare for the next health crisis, which will come, should preventing and treating NCDs be better integrated into pandemic preparedness itself? Open to all three of you.
Well, if I may, the association of COVID-19 and cardiovascular disease is likely, but not really proven. So there is anecdotal evidence for example, increased thrombosis even in the coronary arteries, perhaps caused by, but at least associated with COVID-19 infection. So we do know that inflammation in the body, in the system, can aggravate existing atherosclerotic disease. So there is a connection there, which is well defined and well studied. But again, whether it is causative or just associated is not clear. But I think this has also been the case with influenza, a possible relationship between influenza and acute coronary syndromes or other heart disease. So I think we should think about it together. We should get prepared for both, communicable and non-communicable diseases, and we should see the reality, the fact that those patients that fared worse with COVID-19 infection were the cardiovascular patients, and those that were obese fared even worse. So the obese cardiovascular patient really had the worst outcomes with COVID-19 infections. And I think from these facts we should learn, and I think we still have to wait for final reports of the whole pandemic phase, analysis of all these factors that I was talking about. So to make causal inferences between this kind of dramatic pandemic and viral infection and cardiovascular disease is still something that needs to be explored more.
Sounds like it's early days in terms of fully incorporating the idea of incorporating NCDs into pandemic preparedness. Tomislav.
But I think what all of this has shown us, again, we return to data, that we need more data. And now the data in Europe is fragmented, so different member states have different rules, different protocols, different standards, ethical standards, or how to use data, different ways how they interpret GDPR. So without creating this European health data space, which was proposed several months ago, I think that we cannot really be prepared for any kind of future crisis. And having this data space is important for three things. So I think first it facilitates cross-border provision of healthcare, because the healthcare professionals can get the data from patients from other member states instead of having to do all of the tests and diagnostics again for the patients who come to them from other member states. It's important for research innovation. It's crucial for research innovation, this so-called secondary use of data, and it's also crucial for making policy decisions that we are now discussing. So I think that health data data space, to make this health data space really work, in function, is crucial. I'm glad that I was appointed the rapporteur on this file, and I'll do what I can so that we really adopt this in the Parliament, and that we make an agreement with the Council, so that we really create this health data space, because this is one of those few pieces of EU legislation which is really innovative. We are creating something new, completely new.
Yeah.
And I think this is revolutionary. If we can make this work, then our health systems will be much, much better prepared for any kind of future.
Sounds like early days as well, then. It's too early without the appropriate data to fully incorporate NCD treatments into pandemic preparedness. Last comment from you, Marianne? Should we be incorporating NCDs?
On NCDs, you said. I didn't hear that, sorry.
Should we be incorporating NCD treatment and prevention as part of pandemic preparedness, given what we've seen in the last couple of years?
Well, I think it's of course important to keep in mind that these are connected. Colleagues are working very hard on the pandemic preparedness for the future crisis, and we at the NCD and prevention and promotion side do our bit. Of course, we have to collaborate very closely, but just to say that the legal basis is a little bit different on doing a usual kind of health promotion and then looking at cross-border healthcare health threats like pandemics or Ebola, etc. Okay. But of course, there are links, and the research is especially important on long COVID that Professor Weininger also mentioned. I think we will also meet with the European Cardiology Association on Friday. Tomorrow, in any case, we will continue these discussions there.
Lovely, thank you very much. Well, this brings our fantastic exchange to an end. Thank you so much to our wonderful panelists, Franz Weidinger, Marianne Taki, and Tomislav Sokol. So we've heard just how much the pandemic has affected non-communicable diseases, including when it comes to the treatment and screening backlog. But it sounds like what we really need is better data. And I would argue that perhaps what we really need most is long-term political vision to best tackle diseases that take many decades at times to develop. With that said, thank you once again to our panelists and to each of you for your attention. We ask that you please remain seated because the next session is about to start right away, and it will be my colleague Carlo Martuscelli diving into obesity as Europe's misunderstood healthcare challenge. With that, thank you very much.